Thank you very much, Weng, for that kind introduction. So today I would like to present the Joint Consensus Management on Allergic Rhinitis, which was actually formulated by our rhinology working groups from the section of Rhinology, Department of Otorhinolaryngology, as well as those from the section of Allergy and Immunology of the Departments of Pediatrics and Internal Medicine at the University of the Philippines, Philippine General Hospital. So these are the otorhinolaryngologists involved in allergic rhinitis working groups, which work closely with the allergists from the allergic rhinitis working groups from the Departments of Pediatrics and Internal Medicine. So the objectives for our consensus was, we formulated this consensus in preparation for a UP-PGH joint allergy clinic for both adult and pediatric patients. And the consensus was undertaken with the following objectives: to review the evidence and recent guidelines on the diagnosis and treatment of allergic rhinitis. And number two was to develop a working algorithm on the diagnosis and treatment of allergic rhinitis. It was a joint development of a working algorithm, as I said, from both allergic rhinitis working groups, with an independent literature search done by the two working groups, with independent critical appraisal of the articles. There was also an independent development of recommendations and an integration of the two sets of recommendations, followed by a joint discussion and approval of the recommendations. So in this next two slides, I'm going to show you the algorithm that we came up with. It looks like a busy slide, but actually I'm just going to walk you through this one by one later on. So in the first box, it said, we can see that you have a patient that presents with symptoms of rhinitis, which are rhinorrhea, sneezing, pruritus, and congestion. On the second box, the question is asked, is this history suggestive of allergic rhinitis based on frequency, duration, and severity? If the answer is yes, then we perform a physical examination, anterior rhinoscopy with or without an endoscopy. If the answer is no, then we consider a non-allergic rhinitis, as you see in box number 4. Now, in box number 5, you will see the question is asked, are findings consistent with allergic rhinitis? Again, if the answer is yes, then we consider allergic rhinitis. If the answer is no, then we consider non-allergic rhinitis and manage accordingly. In the 9th box, the answer is, can specific IgE be documented in this patient? Again, if the answer is yes, we perform allergy testing, like either an in vivo testing or a skin testing, or an in vitro testing for serum-specific IgE assays. Again, if the answer is no, then we consider allergic rhinitis, and we can also manage the patient accordingly. And then on box number 13, it says, is the skin test positive? And if the answer is yes, then allergic rhinitis is confirmed. If the answer is no, then we consider local allergic rhinitis or non-allergic rhinitis and manage again accordingly. If you notice in box number 9, we ask the question, can specific IgE be documented in this patient? And if the answer is no, we still consider allergic rhinitis, because there are certain limitations to doing skin testing for specific IgE on all patients, as you will see later on when we discuss this in depth. I'm sorry, so this is on slide 17, on box 17, we classify the patient based on the ARIA protocol, which is the allergic rhinitis and its impact on asthma. It's another consensus document that is widely accepted worldwide. And again, on box 18, once we've classified the patient based on the ARIA protocol, we treat the patient based also on the ARIA recommendations. So you have avoidance strategies, pharmacotherapeutic specific allergen immunotherapy, and patient education. And we will discuss this one by one later on in this lecture. On box 19, the question is asked, is the patient responsive to treatment? If the answer is yes, then they have a patient-family multidisciplinary healthcare provider follow-up. If the answer is no, then we consider severe uncontrolled allergic rhinitis and again, manage accordingly. So this is actually the algorithm that we came up with. And as I said, now we will discuss them one by one. So in box 1, for the history, the patient presents with symptoms of rhinitis, which are the wet symptoms consisting of rhinorrhea, sneezing, and nasal pruritus. And lastly, you have the nasal congestion or nasal blockage. The definition of rhinitis is as follows. It's an inflammation of the lining of the nose, which may present with one or more of the following symptoms. Either an anterior or posterior rhinorrhea, or sometimes what we call the postnasal drip, sneezing, nasal pruritus, and nasal congestion, which may occur for 2 or more consecutive days, lasting for at least an hour on most days. It may or may not be associated with symptoms involving the eyes, the ears, or the throat. In box number 2 for the history, we ask, is history suggestive of allergic rhinitis? So, as we very well know, allergic rhinitis is an IgE-mediated inflammation of the lining of the nose and is considered in the presence of the following symptoms. Usually the wet symptoms, rhinorrhea, sneezing, nasal pruritus, and or nasal congestion, triggered by an exposure to allergens. Usually the top allergens would be dust mites, molds, pollen, and animal dander. It is associated with conjunctival redness, itchiness, or teary eyes with an odds ratio of about 2.85. And usually there's a personal and family history of atopy with a positive likelihood ratios of 2.49 to 6.69. So we know very well that allergic rhinitis is an inherited condition. That's why there's a very strong family history. On physical examination in box 3, we perform a physical examination, anterior rhinoscopy with or without endoscopy or scoping. So a complete physical examination should be done in a patient with allergic rhinitis, paying close attention to the organ systems where comorbidities as well as other atopic diseases may manifest. So these are some of the findings suggestive of allergic rhinitis. These are the facial grimacing, the supratip nasal crease, and the allergic shiners. Allergic shiners are actually these puffy bluish discolorations of the lower eyelids because of the rerouting of blood away from the congested nasal mucosa. It has an excellent specificity, about 100%, and the darkness is actually correlated with chronicity. The anterior rhinoscopy supports but does not definitely establish a diagnosis of rhinitis. You can have findings of pale or hyperemic turbinates, which may be present in patients with allergic rhinitis as well as in those with non-allergic rhinitis. Watery discharge, this mucus threads, areas of congestion like an inferior turbinate contact with the inferior meatus with a positive predictive value of about 83.8%, and contact with the middle turbinate with adjacent structures with a positive predictive value of about 86.2%. So these are the findings that you may see during your anterior rhinoscopy and or endoscopy that would be highly suggestive of allergic rhinitis. So with anterior rhinoscopy, as you can see on the left diagram, it's usually done using a nasal speculum, okay, by usually an ENT specialist using a head mirror or a headlight. And on the right, you will see that endoscopy is being done with a rigid endoscope. Okay, findings may be varied, as I mentioned. You may have a hyperemic or pale mucosa, as you can see in the upper picture, and you can have some evidence of mucus threads at the back of the nasopharyngeal area, as you see in the bottom diagram, which may account for the post-nasal drip that many of these patients complain of. So again, as part of physical examination, this nasal endoscopy is performed in certain situations. In the presence of atypical symptoms or physical findings, the occurrence of complications with other conditions, and those with inappropriate response to therapy. As you can see with endoscopy, you have a more detailed and accurate visualization of the internal nose. As you can see, you can have stringy mucus, as seen in the very first diagram. You can see the contact areas of a swollen turbinates against the walls of the nasal cavity. You can see some polypoid changes in the middle meatus, as you can see in the last diagram. Now, in box number 9, the question is asked, can specific IgE be documented in this patient? The American Academy of Asthma, Allergy, and Immunology recommend confirmatory testing when suspecting allergic rhinitis. However, no present evidence supporting the superiority of confirmatory specific IgE testing over empirical trial with medication. And there are certain clinical modulating factors, such as the cost, the geographic constraints, the availability, and the quality control of the skin testing. But just the same, our rhinitis working groups actually adopted the recommendation of the American Academy of Asthma, Allergy, and Immunology. So skin testing merely confirms the sensitivity to the allergens. And the contraindications of skin prick testing are those with diffuse dermatological conditions, severe dermatographism, poor subject cooperation, and when the patient is unable to cease antihistamine or other interfering drugs. Because usually antihistamines are actually stopped about 4 to 6 days prior to the initiation of skin testing. And other relative contraindications to specific IgE skin testing would be persistent, severe, or unstable asthma. Those are pregnant, patients who are on beta blockers, and as I said, there's also the cost considerations. Now, the kind of allergy testing that we recommend in our consensus statement is the skin prick testing, and the most commercial specific IgE assays display a good sensitivity but a lower specificity. So skin prick testing and specific IgE tests, meaning in vitro and in vivo testing for IgE, are complementary. In certain circumstances only, however, can they enhance diagnostic accuracy, especially when a test is negative despite a suggestive history of allergy. So the combined use of both tests can enhance the diagnostic accuracy. So that's both the in vitro and the in vivo test. Now, skin testing represents the primary diagnostic tool in allergy that is used to confirm that a specific allergen suggested by the medical history has induced an immunoglobulin or IgE antibody response, or what we call sensitization. And indications would be for seasonal rhinitis, or treatment sensitive, those with associated pollen-induced asthma, and those with associated severe pollen food syndrome. And also in patients who have perennial rhinitis, and the causal allergen is not always, when the causal allergen is not always immediately apparent. Now, the proper interpretation of the skin test must be emphasized. Positive skin tests alone in an asymptomatic patient does not automatically mean that the individual is atopic or allergic. It may predict subsequent clinical allergy, especially if the wheal size is greater than or equal to 4 millimeters. And a positive skin test that correlates with the history suggestive of clinical sensitivity strongly indicates the allergen as the cause of the disease. And a negative skin test with a negative clinical history makes an allergic condition most unlikely. Okay. Special clinical conditions warrant the use of specific IgE Immunoassay. So these are your in vitro testing, are recommended in special clinical conditions where there is widespread skin disease, which is for self-explanatory, skin test suppressive therapy, those uncooperative patients, and those with unusually great risk of anaphylaxis from skin prick testing. Okay. Now we go to the treatment. Okay, as I said earlier, the patients, once we have confirmed that they have indeed allergic rhinitis based on history, physical examination, and allergy testing, they are now classified based on the ARIA protocol into either patients with intermittent symptoms or those with persistent symptoms. That is based on the duration, and again, based on the severity, as mild or moderate to severe. So those with intermittent rhinitis, allergic rhinitis, are patients who have symptoms less than 4 days per week or less than 4 consecutive weeks. And patients with persistent allergic rhinitis are those with symptoms greater than 4 days per week and greater than 4 consecutive weeks. In terms of severity, mild allergic rhinitis are characterized by patients who have normal sleep with no impairment of their daily activities, sport, leisure, no impairment of school or work, and symptoms are present but not troublesome. Now, patients with moderate to severe symptoms have one or more of the following items: sleep disturbance, impairment of daily activities, sport or leisure, impairment of school or work, and those with troublesome symptoms. So once they're classified, they're also treated according to the ARIA recommendations. As you can see, patients with a mild intermittent rhinitis will benefit from oral or local non-sedating antihistamines, leukotriene receptor antagonists or anti-leukotrienes, intranasal decongestants or oral decongestants, and allergen and irritant avoidance. Okay, it pays to take note that allergen and irritant avoidance are actually the best way to treat allergic rhinitis. Unfortunately, it is oftentimes impractical, if not impossible. And that is why we normally rely on pharmacotherapy, see in this slide. So the use of intranasal steroids actually begins, according to the ARIA protocol, with a moderate to severe intermittent, all the way to the moderate to severe persistent, as you can see in this slide. Again, this is the algorithm shown by this is just a summary again of the treatment algorithm recommended by the ARIA protocol. So again, after the diagnosis of allergic rhinitis by history, skin prick testing, or serum-specific IgE, as we have just discussed, allergen avoidance is always suggested, but I said it's always, oftentimes it's impractical, if not impossible. So we rely on pharmacotherapy. So for those with intermittent allergic rhinitis, mild intermittent allergic rhinitis, the ARIA protocol recommends a use of oral H1 blocker, not in the preferred order, an intranasal H1 blocker, and or decongestant with a leukotriene receptor antagonist. For those with moderate to severe intermittent symptoms, as well as those with mild persistent symptoms, they recommend, again, an oral H1 blocker, intranasal H1 blocker, and or decongestant, an intranasal corticosteroid, and an anti-leukotriene an anti-leukotriene medication. Now, for moderate to severe persistent rhinitis, they start with intranasal corticosteroids with an H1 antihistamine or an anti-leukotriene. And the patient is usually reviewed after about 2 to 4 weeks. If there is an improvement, there's a step down and the treatment is continued for another month. If there is a failure, the diagnosis is reviewed and compliance is also reviewed, and we indicate for other causes. And you can either increase the intranasal corticosteroid dose. You may add an H1 blocker to get symptoms of itching, sneezing. You may add an ipratropium bromide for troublesome rhinorrhea. Okay, and you may add a decongestant or short-term oral corticosteroids if blockage is the most prominent symptom. In spite of all these, if there is still failure, then a surgical referral is made. Okay. So, and immunotherapy is considered, if you see there on the left-hand side, immunotherapy is considered for moderate to severe intermittent rhinitis or mild, moderate to severe persistent rhinitis. Immunotherapy may be considered in those conditions. Okay. As I said, avoidance environmental control are always part of the treatment strategy. However, the clinical benefits of inhalant allergen avoidance, with the exception of a multifaceted house dust mite control measures in treating allergic rhinitis symptoms, are controversial due to the lack of adequate clinical trials. So most of the allergen avoidance intervention trials were related to asthma and not to allergic rhinitis. So there are certain situations that warrant avoidance environmental control, like in primary prevention for the prevention of the development of allergic disease, and for tertiary prevention as in the treatment of existing allergic disease. So as I said, we normally rely on pharmacotherapy since avoidance is impractical, if not impossible. And there's several medications that we can discuss under pharmacotherapy. The mainstay is oral H1 antihistamines are recommended for use as first line of treatment among patients with mild or moderate to severe allergic rhinitis, even among children. The older generation antihistamines, however, have very bad side effects by virtue of their anticholinergic effects, which can give dry mouth, a urinary retention, the tachycardia. However, because of these anticholinergic effects, they have a better control of the rhinorrhea. The newer generation antihistamines are the strongly preferred ones. They're more specific for H1 receptors with anti-inflammatory effects, and they can reduce also the ocular symptoms of itching, tearing, and redness. It has less side effects on cognition and sedation, and it is effective on a need basis, but work best with continuous use. And the reason for this is because they have a rapid onset of action. Okay, so here are some of the examples of the new generation antihistamines. You have the cetirizine and its enantiomer levocetirizine. They're both excreted and changed in the urine and safe for pregnant women and can be taken for long-term use up to about 18 months, even for children. When cetirizine is compared to loratadine, it has a more rapid onset of action, and it is active immediately after absorption. Unfortunately, in about 12% of patients, it can have a side effect of sedation. The enantiomer of cetirizine has an anti-inflammatory effect, aside from its antihistaminic effect, and as such, it can reduce nasal congestion and can provide greater relief than Montelukast, which is an anti-leukotriene. So combined with Montelukast, it affords better control. So there are a lot of medications right out there in the market that now combine levocetirizine together with Montelukast. Now, loratadine, we've touched on it earlier, and its active metabolite, desloratadine. No. It is, loratadine is transformed to active metabolite in the liver, which is desloratadine. It's also safe for pregnant women. It can also relieve ocular symptoms. Now, desloratadine has the ability to avoid interactions with drugs that inhibit the cytochrome P450, but the most common side effect is hexofenadine and loratadine. It can significantly reduce the frequency of nighttime awakenings. The other one, two other antihistamines in the market are the fexofenadine, which is an alternative to terfenadine, which was actually taken off the market. It's a wide therapeutic index. It has 20 milligrams twice a day with the minimal effective dose. And dosages of 360 milligrams per day can provide has no adverse effects and do not lead to sedation. In fact, some say that fexofenadine is truly the only non-drowse antihistamine. And so far, it is the only antihistamine that has been approved by the U.S. Transportation Agency for pilots. And versus chlorpheniramine, it has less ability to effectively relieve anosmia and nasal pruritus. Ebastine has a different E structure. It has less ability to relieve the nasal congestion, and it's safe for 3 months use. And versus cetirizine, it has increased efficacy if dose is doubled. So those are the oral antihistamines, and we now go to the intranasal antihistamines. Intranasal H1 antihistamines include azelastine and olopatadine, and can be also used as first-line treatment for patients with seasonal allergic rhinitis. Versus oral antihistamines, they have certain advantages. They are more effective relief of nasal congestion. They have a faster onset of action than oral antihistamines. They have less risk of systemic side effects because they are topical. However, the efficacy is uncertain, and it has a very bitter taste, and it can cause also sedation, and it requires frequent administration. So those are just some of the disadvantages of using intranasal antihistamines. So these are your azelastine. It's a second-generation antihistamine, and it comes as a 0.15% nasal spray at 2 sprays per nostril once a day or twice daily. And the onset of action is between 15 to 30 minutes. The most common adverse event that reduces patient compliance is its bitter taste. Now, olopatadine, on the other hand, is a selective H1 receptor antagonist and mast cell stabilizer. It comes as a 0.6% nasal spray. It can be used in children 6 years of age and older. Okay? Versus an intranasal corticosteroid spray like fluticasone propionate, 50 micrograms, it has a faster and greater onset of action. So olopatadine is now also being combined with fluticasone. Now, the intranasal corticosteroids are considered the most effective pharmaceutical treatments for nasal allergic rhinitis symptoms and are recommended as first-line therapy for moderate to severe symptoms. They control and reduce the 4 main symptoms of allergic rhinitis, and that is the wet symptoms of itching, sneezing, running, as well as blocking. In children, we have to give the lowest effective dose, and they're effective in patients with seasonal allergic rhinitis, but not as effective, again, as continuous use. They can be given as PRN, but it's not as effective as giving them on a maintenance basis. Intranasal corticosteroid sprays may be the initial treatment even without a trial of antihistamines or antihistamine decongestant combinations. These should be given before starting oral corticosteroids. So for severe symptoms of allergic rhinitis, you can actually start with intranasal steroids alone, or you may combine them with antihistamines. And the proper technique is very important. You should spray, they should be directed towards the outer corner of your eye, away from the septum, because one of the side effects of intranasal corticosteroid sprays is epistaxis, and this is most likely because of improper technique by pointing it towards the septum. So the fluticasone furoate has the highest retention in nasal tissue. It has the highest anti-inflammatory activity with consistent ocular and nasal efficacy with improvement in quality of life. It has a low systemic bioavailability, and it's safe and tolerable for 1-year use. Its predecessor was an established intranasal corticosteroid. It can also improve the nasal symptoms, daytime sleepiness, and cognitive performance with a low systemic bioavailability. So the furoate was actually just an improvement on the fluticasone propionate. The mometasone furoate is another established intranasal steroid. It treats itchy ears and palate in individuals with seasonal allergic rhinitis. It also improves nasal symptoms, quality of life, sleep quality, and upper airway conditions in Japanese subjects with perennial allergic rhinitis. It has very low systemic bioavailability, and it's safe for 1-year use. Seclesonide is one of the newest in the market, contains no benzalkonium chloride or phenylethyl alcohol. It comes in a hypotonic suspension, which can optimize intranasal absorption. And the onset of action is about an hour after the administration. Now, oral corticosteroids may be recommended for patients with severe or intractable symptoms of allergic rhinitis only for short durations. So these are, when you say short course, it's about 5 to 7 days, and usually given to patients with severe persistent disease not responding to the usual treatment. Now, your leukotriene receptor antagonists or your anti-leukotrienes alone or in combination with antihistamines may be recommended for patients with allergic rhinitis. Actually, in the original ARIA protocol, this was not mentioned, but in the most recent ARIA protocol, anti-leukotrienes have now become part of the treatment regimen. They have shown to decrease rhinorrhea, sneezing, and nasal congestion. However, their effects less predictable than intranasal corticosteroids or antihistamines. And usually they are given for patients with concomitant asthma and allergic rhinitis. Okay. Decongestants are quite well known to all of us. The oral intranasal decongestants may be recommended for allergic rhinitis with prominent nasal congestion, but should be used for short duration due to the risk of rebound rhinitis or rebound congestion. It has no effect on the wet symptoms, sneezing, pruritus, and rhinorrhea, and non-nasal symptoms unless combined with oral antihistamines. Okay. Some of the well-known side effects of all decongestants are loss of appetite, insomnia, irritability, and increase in blood pressure is occasionally noted. Topical decongestants, the most adverse effect, as I mentioned, is rebound rhinitis, or what we call rhinitis medicamentosa, which can come as early as within the first 3 days of use, especially for patients who have pre-existing nasal sensitivities, such as patients with allergic rhinitis. It can also come as late as more than a week after the treatment. Now, omalizumab is a currently approved anti-IgE medication for the treatment of severe persistent allergic asthma that is refractory to all other available treatment. So it is a monoclonal antibody against IgE, which binds to the constant region of the IgE molecule, blocking the cross-linking of the antibody, of the IgE molecules to the surface of mast cells and basophils. So it reduces the free IgE concentrations. However, more clinical trials are needed to evaluate its use in allergic rhinitis because most of the studies are on treatment of asthma. Now, specific allergen immunotherapy, or SIT, SIT, is the best treatment option that is a treatment option that may potentially alter the course of IgE-mediated respiratory allergies and thus possibly provide long-term effects. It can reduce overall nasal symptom scores, reduce nasal, ocular, bronchial symptoms. It can improve allergic rhinoconjunctivitis quality of life scores, reduce the use of medications, reduce the risk of developing bronchial asthma in children, and prevents the development of new allergen sensitizations. So specific allergy immunotherapy is actually the best treatment modality. It's a more definitive treatment modality for treating allergic rhinitis. Unfortunately, it entails a tremendous investment in terms of time and resources. So this is quite a busy looking slide, but basically, in theory, specific immunotherapy relies on the induction of host IgG blocking antibodies, as you can see in the bottom half of the slide, that are specific for the antigens to which a patient is sensitive to. So the production of these blocking antibodies effectively block the interlinking of the IgE molecules on the surface of your mast cells as well as your basophils. So this is done by actually progressively exposing the patients to increasing quantities of the allergen to which the patient is sensitive to produce a host IgG blocking antibodies. So basically, that's the mechanism of action. And their therapeutic effects can be achieved in about 8 to 12 weeks for the early effects. The effects can persist for as long as 3 to 5 years, and even 2 to 6 years thereafter. In children, they have been found to prevent new sensitivities and the progression of disease from allergic rhinitis to bronchial asthma. So there are a lot of benefits actually for doing specific immunotherapy. So the indications again depends on the severity and duration of symptoms. As I mentioned earlier, you can give them for patients with moderate to severe symptoms and for those with more perennial symptoms. Okay? It also depends on the responses to other forms of therapy. Those who have unacceptable adverse effects to medications, if the patient desires to avoid long-term pharmacotherapy, then immunotherapy must be right for them. Those with reduction, those who opt for reduction of the risk of future asthma, and presence of comorbid conditions such as sinusitis or asthma. So these are the patients who may benefit well from immunotherapy. The contraindications are those with severe uncontrolled asthma, and those with significant or unstable cardiovascular disease, and those with mental incapacity. So, considerations in doing immunotherapy, there should be a very careful selection of patient and allergen extracts. So there will be allergic asthma, for patients with allergic asthma, younger adults with standardized extracts. Okay? The benefits of treatment must outweigh the risks of adverse events like anaphylaxis and prolonged treatment course. And they should only be considered after strict environmental control and failure of pharmacological intervention. So patient education is extremely important. The education of the patient, family members, and caregivers is crucial in promoting the compliance to management and maximizing the treatment outcomes in allergic rhinitis. And the role of the physician should demonstrate sensitivity to the socioeconomic and demographic characteristics of the patient. We incorporated this because these are the kind of patients that we normally see in PGH, from very various socioeconomic and demographic backgrounds. So the role of physicians is to explain the chronicity of the disease and the roles of allergen avoidance and control. She should be able to provide realistic treatment goals and instruct on the proper administration of medications, the use of devices, and the benefits of adhering to treatment. Should be able to explain the possible development of comorbidities such as bronchial asthma, otitis media, nasal polyposis, and sinusitis, and explain the positive impact that disease control could have on the quality of life. Cooperation in working to achieve the goals of reduction of symptoms, improvement in the quality of life, and increased ability to function is also necessary. So during follow-up, this has to be emphasized. No? If there's a positive improvement, then we can start tapering the medications. If there are no improvement, then we have to step up the treatment. And the quality of life assessment should always be part of the post-operative of the provider follow-up. Now, just a few slides. So these are just other conditions that we decided to include in our sense. If a patient presents with chronic nasal symptoms such as obstruction and rhinorrhea, but has a negative skin prick testing and absence of serum IgE, consider what we call non-allergic rhinitis. These are usually patients who present more with blocking, nasal congestion, and rhinorrhea. They develop symptoms at a later age, and the common triggers are barometric, no? Changes in weather and temperature, food, perfumes, odor, smoke, which are not the common triggers when it comes to allergic rhinitis. So there are 8 subtypes. You have the non-allergic rhinopathy, which is previously known as vasomotor rhinitis. You have the non-allergic rhinitis with eosinophilia, atrophic rhinitis, senile rhinitis, gustatory rhinitis, drug-induced rhinitis, including rhinitis medicamentosa, hormonal rhinitis, including the rhinitis of pregnancy, and the CSF leak. So these are all classified as non-allergic rhinitis. Now, this is a bit confusing, but an entity has now come up recently, and it's called local allergic rhinitis. So the patient presents with symptoms similar to allergic rhinitis, but has negative skin prick testing and positive nasal mucosa production of specific IgE antibodies. Then we should consider this patient to have local allergic rhinitis. So the pathophysiology is such that there is a local production of specific IgE antibodies in the mucosa, and there is it's the same type of inflammatory pattern, which is a T helper type 2 inflammatory pattern of mucosal cell infiltration during natural exposure to aeroallergens. And it's a positive nasal allergen provocation test. Okay. So those with persistent local allergic rhinitis and moderate severe symptoms will also benefit from intranasal steroids as well as oral histamines. However, further research is necessary on specific immunotherapy with aeroallergens. Now, severe uncontrolled allergic rhinitis, I think this is the last slide, are patients with symptoms who are inadequately controlled despite effective, safe, and acceptable pharmacologic treatment based on the guidelines. Factors to be considered in the treatment should be disease-related, such as environmental factors, diagnosis-related, the possibility of having granulomatous diseases, and the treatment-related factors. So there should be a reevaluation of pharmacotherapy in either to step up the treatment. I think that's it. That's the last line. So that's a picture of our whole allergic rhinitis working group. Thank you.
Thank you for that very insightful and informative lecture, Dr. Lopa. And also our sponsors for today's webinar, JSK and Westmont for Pharmaceuticals. I'm Rina Quintos, and I'm the moderator for today's question and answer portion. We're ready for question. Here we have one question. The question is, does the ENT doctor do skin testing for allergies?
No, we don't. We normally refer to this consensus document was actually formulated that we could actually work hand in hand, with our allergy colleagues, with our allergy colleagues, as well as from the Department of Pediatrics, as well as from the department. We normally refer them to the allergists to do it. We normally refer them to the allergists to do it.
We have another question. How long do patients have to be off any meds for allergic skin testing?
As I mentioned earlier, should be off for about 4 to 6 days.
Okay, we have another. Randy. What's your experience in finding what constitutes LMR treatment of allergic rhinitis?
I have a very good experience, and I think it's going to be a first-line treatment, a combination of anti-mucotriene and antihistamine in a single medication. is going to be a very good choice. In fact, it was incorporated in the latest ARIA protocol, where it was not indicated in the very first one in 2001. So I'm very happy actually with the results using a combination.
And then another question is, are there new treatments in the horizon for allergic rhinitis?
Yes, as I mentioned, there's an anti-IgE medication, omalizumab, as I mentioned earlier. Unfortunately, we need more clinical trials because clinical trials on the anti-IgE medication on asthma. So, but that is something very promising in the horizon.
Okay, we have many questions here. Another is, at what point will you consider nasal ciliary biopsy, ciliary dyskinesia?
This will probably be an patients who have severe, who seem to have some severe rhinitis symptoms that don't seem to respond to medications, together with other comorbidities, because a lot of patients with primary ciliary dyskinesia will have other comorbidities like rhinitis media with effusion. Those they may also have chronic respiratory conditions together with asthma, and I would probably begin to suspect, as you can see in the algorithm, they no longer restrict one of the ARIA profiles, you will see that when there is a severe uncontrolled allergy, it's time to actually investigate for other possible things. And one of them is primary ciliary dyskinesia.
Okay, as of 12:51 today, we have 54 attendees, and from live stream, we have 6 participants, 3 from the Philippines, 2 from the US, and 1 from Canada. Do we have other questions? If there are none, thank you, Dr. Lopa, for the very engaging discussion. As a summary, we learned that history and physical examination is very important, as well as also endoscopy. You also told us when to do allergy testing. You showed us the ARIA classification and treatment algorithm. You also touched on immunotherapy, very important topic of patient education in the treatment of allergic rhinitis. Also, we learned today about the new disease or local allergic rhinitis. Thank you very much, Dr. Lopa. There's one more question. Last question. Okay. I often see allergic rhinitis and sinusitis as comorbidities. When do you decide to start antibiotics in the absence of the usual local signs or fever?
Yeah, that's a very good question. Actually, when you speak of allergic rhinitis, I think the more proper term is allergic sinusitis, because the lining of the nose and the lining of the sinuses are practically one and the same. And any inflammatory condition happens in those sinuses. So I think the more appropriate term is really allergic rhinitis. But when do you employ, when you start using antibiotics, it's usually, this is the time that you actually need to do an endoscopy in the patient to see findings, endoscopic findings that would suggest really a superimposed bacterial infection, such as a mucopurulent exudates in the middle meatus, swollen or edematous middle meatus, probably polyps, inflammatory polyps, and that's the time probably start giving antibiotics to, because it has been shown that patients with allergic rhinitis, patients with allergic rhinitis are 4 to 5 times more likely to develop a bacterial infection more viral condition, cold, than patients who do not have allergic rhinitis. So they're actually 4 to 5 times more likely to develop the bacterial signs like this. So we should always be on the lookout. So it's not only in terms of time and duration of the symptoms, but it's also based on the physical examination. That's when it also becomes very important. So you can actually visualize the nasal cavity much closer.